Welcome to this session on drugs affecting microorganisms. We're going to look at the principal antibiotics that are used to treat bacteria and resistant strains and how that resistance might have developed. We'll look at the modes of action of penicillins, cephalosporins, quinolones, macrolides and tetracyclines. We'll also look at a sulfonamide trimethoprim combination which uses synergism of action, so we'll look at that mode of action. And last of all, we'll look at a chemical class of drugs that isn't used to kill bacteria, but is used to treat acne, the retinoids. There are many microorganisms that cause infectious disease, including bacteria, mycoplasmas, protozoans, viruses, and fungi. It's important to use the appropriate pharmacological treatment for the infectious disease. So what antibiotic is used will depend upon the microorganism responsible for the infection. The treatment aim is to match the spectrum of activity for the drug to include that causative microorganism and to do antibiotic sensitivity testing in culture of that pathogen. Bacteria are either gram-positive or gram-negative. Once they're cultured, they are then stained, and this is used to identify them. Gram-positives are more purple because they hold on to more of a purple dye, and they hold on to it because they have a thicker peptidoglycan layer. Gram-negative bacteria do contain that peptidoglycan, but because it's so thin, they lose the purple dye and will then stain red with a counter stain. If you want to know how to kill bacteria, it's also important to know how they live. So aerobic bacteria live in the presence of oxygen. This will include organisms such as Staphylococcus aureus, which grows on the skin. Anaerobic bacteria live without oxygen. A good example would be Clostridium tetani. This organism grows in soil. It can get into superficial wounds. If the conditions are anaerobic, the endospores will germinate there. The vegetative cells that grow from those spores are metabolically active and produce the tetanus toxin. This toxin travels through the systemic circulation to the brain, where the person then shows all of the symptoms of tetanus, the locked jaw first, or actually diplopia, problems with the cranial nerves first, then locked jaw, and then the condition can progress from there. Antibiotics are used to treat bacteria. They are natural substances produced by another organism. That organism could be a bacterium or a fungus. Then they are cultured in laboratories. They also tend to be synthetically modified, and the synthetic antibiotic is given. Rather than one derived from the organism, it's altered so for various reasons which we will look at. Each antibiotic has a unique spectrum of activity that might include certain gram-positive organisms, or it might be very broad spectrum and include gram-negative organisms. The spectrum of activity might include anaerobic bacteria. The first major class of antibiotics to be discovered were the sulfonamides in 1933, and the second major class, the penicillins, in the 40s, in response to World War II and the need to find an antibiotic to target infections. The aim of the therapy with an antibiotic is to kill the bacteria, in which case the agent would be called bactericidal, but finding an agent that is bacteriostatic is still efficacious because the human's immune system can fight the infection even though that antibiotic is not directly killing the bacteria. There are four main mechanisms of action of antibiotics. They can either inhibit cell wall synthesis. This will cause the cell wall to be weak, it will break open, and the cellular contents will leak. So as you can imagine, this would be quite bactericidal. Antibiotics can also disrupt the membrane and its permeability, leading to loss of metabolites and substrates. Antibiotics that work by this mechanism of action can be bactericidal or bacteriostatic. We will look at some examples of some antibiotics that inhibit protein synthesis in bacteria, and once again these agents can be bactericidal or can be bacteriostatic. We'll see that the ribosomes in bacteria are unique because bacteria are prokaryotes. Their ribosomes are completely different to mammalian ribosomes, so the human, in theory, will show fewer adverse effects to that antibiotic because their cellular structures will not be affected. And last of all, the other main mechanism of action of antibiotics is to inhibit at a pathway that involves a particular essential metabolite. And these antibiotics tend to be bacteriostatic, therefore relying on the human's own immune response to actually kill the bacteria. Antibiotic resistance is a distinct problem in pharmacotherapeutics using antimicrobials. There are many mechanisms that bacteria and other microorganisms can use to counteract the effects of antibiotics. The first mechanism that we've given there as an example occurs with organisms such as Pseudomonas. Pseudomonas can cause sinusitis infections, urinary tract infections, and this organism can produce a particularly slimy layer around itself. And because of this slime, the antibiotic just simply cannot get through and is prevented from reaching its target. Bacteria might also produce an enzyme that directly metabolizes and degrades that antibiotic. This is the case with antibiotics that are called beta-lactams. This includes the penicillins and cephalosporins. In their structure, they contain a particular beta-lactam ring. Certain strains of bacteria produce an enzyme that breaks down that ring, and as we'll see, its shape and structure is critical to inhibiting a bacterial enzyme. And these bacterial strains have found a way of being resistant. And the way they found a way was simply that in the presence of the antibiotic, sensitive strains were killed off, and those that by sheer random chance had this mutation that enabled them to degrade beta-lactam were the ones that survived that antibiotic therapy. So they then grew up in large numbers. So it's not that the bacteria choose to have this structure, it's just a natural selection process happening in response to the use of the antibiotic. And other than that, it's just sheer random chance and mutation. Bacteria can also alter the target binding site of the drug so that that drug no longer binds. Once again, recall that it's just that by sheer random chance in the population there is differences due to mutations where some bacteria will have slightly different binding sites to other strains of that bacterium, and in the presence of the antibiotic, those that are affected are killed off. Those that had this slightly different shape to the binding site are less susceptible to the antibiotic, are not killed, and then will overgrow if given the right conditions. Some bacteria can produce chemicals which will actively pump a drug out of the cell. This occurs with tetracycline resistance. So once again, it's just sheer random chance and mutation in bacterial populations, but in response to the use of tetracyclines, those that don't have that active pump are killed off, and those that do survive, overgrow, and in the right conditions can infect other people, leading to the emergence of resistant strains. Last of all, bacteria can have enzymes that are no longer affected by the antibiotic because they've found another set of enzymes, a different pathway that will then bypass the one that is being inhibited by the antibiotic. So to look at a diagram showing all of those mechanisms of action for antibiotics and where resistance can occur. First of all, at the cell wall, if an antibiotic particularly targets the cell wall, strains of bacteria can show a change in that cell wall structure or outer membrane composition. There might be also altered channels in that particular membrane, and these are called porin channels in bacteria. It might also be the synthesis of those porin channels that has changed. We then said that there are those strains that might have an efflux pump. They transport the proteins, they transport the antibiotics via these proteins out of the inside of the bacterial cell into the external environment where they cannot have their effect. There are those strains of bacteria that can produce a biofilm called an extracellular glycocalyx, or to put it simply, that slimy layer. So that was Pseudomonas. The penetration of the antibiotic is just much less. There is a delay in the absorption of that antibiotic into the bacterial cell. So next, bacterial strains might inactivate the drug. This was the case with bacteria that can produce beta-lactamases that actively destroy the beta-lactam ring in the cephalosporins and penicillins. By sheer random mutation, there may be some bacteria that have an altered drug target shape, and so the active drug won't actually bind on to its target in these strains. So the susceptible strains are killed off, and those that have the mutation are the ones that are selected. So a modification of the target site and its shape or affinity. The next is where bacteria might just overproduce the drug target. There is reduced effectiveness of the antibiotic, might lead to the need to use an excess of the drug, but because this drug has adverse effects, and that's usually dose dependent, that's often not an option when a bacterium becomes resistant by that mechanism. And then last of all, if there is a particular metabolic pathway where an enzyme is inhibited, bacterial strains that have a different set of enzymes and can bypass that pathway will survive in the environment of using that antibiotic, and they will survive and perhaps in the right conditions can overgrow. Ways to combat antibiotic resistance: encouraging clients to use antimicrobials for the full course of treatment. The missed dose is always a problem, but if you can educate clients about not missing the dose of an antimicrobial and the reasons for it. It's important that doctors do not overprescribe antibiotics for infections that they are simply not going to work against, such as the flu, not prescribing unless the doctor is sure that there is a secondary bacterial infection that might be causing the ongoing symptoms that the person might be experiencing. So selective control, restriction of use and removal of antimicrobial agents or classes is another method. We'll see an example of a restricted use antibiotic. Use of antimicrobial drugs in a rotational or a cyclical pattern, or use of combinations of antimicrobials. This will prevent the emergence of resistance because it is sheer random chance, it is mutation, and the chance of that strain having a resistance mechanism to two drugs is virtually impossible. Superinfection is when there is use of an antimicrobial for therapy or prophylaxis, and antibiotics eradicate the normal flora which are susceptible to that antibiotic. Then there will be overgrowth of normal microbial flora that had some resistance mechanism, so endogenous bacteria that overgrow. But it might also be an exogenous strain of the microorganism that can then overgrow simply because the normal microbial flora are not present and are not blocking the receptor targets. So these bacteria are able to attach and then overgrow. If the number of replacement organisms is large enough and other host conditions favourable, then a clinical superinfection can occur. We stress there are certain host conditions, perhaps they are immunocompromised, and this is why these superinfections tend to happen in hospitals. Various prescribing guidelines given by the Therapeutic Goods Administration, the Therapeutic Guidelines for Antibiotics 2000, use antibacterials only when indicated. Best to identify the infecting microorganism by culturing it. Do an antibiotic sensitivity. Give the agent to which that culture is susceptible, and avoid using any antibiotic to which that microorganism was resistant, as seen in those agar tests. Use a drug with the narrowest spectrum of activity. So if you use a broad spectrum antibiotic, you'll just simply be encouraging resistance among strains of bacteria that aren't even causing the infection, and encouraging resistance. Use a single drug unless a combination therapy is available. Use a drug dose that's high enough to ensure efficacy, but also not to cause toxicity and reduce the likelihood of resistance appearing. Use antibiotics for a short duration, so only a week, and only continue the antibiotic therapy beyond that week if there were clinical reasons, if there was some evidence requiring a longer duration. It's important to recognise that the role of the host defence mechanisms are very important in targeting infectious diseases. The antimicrobial agent should not have any effect on the human's natural defence mechanisms. They should still be able to operate. So in people who are immunocompromised, they are often at risk of infection, and the host defence mechanisms may not be able to help out with bacteriostatic agents. So people who are immunocompromised might include people with diabetes mellitus or cancer, and people who are HIV positive for whom their T4 cell count has started to drop, might become immunocompromised. So first of all, the first chemical class, the penicillins, different from the cephalosporins, but they both contain a beta-lactam ring. These antibiotics are bactericidal and inhibit peptidoglycan in the cell wall, and the cell contents just simply leak out. The carbapenems are one of those class of drugs that are withheld and reserved and only used if there is a penicillin-resistant strain, a resistant hospital infection such as methicillin-resistant Staphylococcus aureus. Beta-lactam antibiotics have a wide range of indications, probably the most broad. They're used for skin infections, respiratory infections, urinary tract, CNS infections, sexually transmitted infections, typhoid and rheumatic fever if the organism is susceptible. So, bactericidal, inhibits cell wall synthesis. The particular way that they will do this, such as the penicillins, benzylpenicillin, ampicillin, amoxicillin or flucloxacillin, they target a particular bacterial enzyme called transpeptidase. The active site for this enzyme normally uses a particular peptide structure in the forming peptidoglycan chains. And because the beta-lactam antibiotic is so physically similar, it locks into the transpeptidase enzyme instead, irreversibly blocking it, and therefore less cross-linking occurs in the peptidoglycan structures. It's not as strong a cell wall structure. The cell contents then leak as a result, leading to cell lysis and eventually death. The adverse effects of the penicillins, you'll start to see a common theme. Most of the antibiotics have gastrointestinal symptoms, but in addition penicillins will cause headache, a sore tongue or mouth, and they will kill off normal flora microorganisms, allowing candida to overgrow. The candida might overgrow in the mouth or the vagina because the lactobacilli that would normally make the vagina acidic and inhibit any commensal candida are removed, and so the vaginal environment becomes less acidic. Another common theme with most of the antibiotics will be allergic reactions. In penicillin, there can be severe anaphylaxis, that hypersensitivity type 1 reaction, or it might be hives or pruritus, itchiness. When taken, they may decrease the effectiveness of the oral contraceptive pill. We'll look at that when we look at other drug interactions. Penicillins will also interact with anticoagulants, an increased risk of a bleed. With the oral contraceptive pill, the effectiveness is reduced. So the normal flora bacteria are not present in the gut. It might lead to diarrhea, impaired absorption of the oral contraceptive pill, and this will lead to contraceptive failure or perhaps breakthrough bleeding. With the non-steroidal anti-inflammatory drugs, there is an increased risk of a bleed, so this is an adverse effect of the non-steroidals, and this adverse effect is being made greatly enhanced with the use of penicillins, and probenecid will prolong penicillin activity. So it's contraindicated in people that have a general allergy or a specific penicillin hypersensitivity. Salt-restricted diet, people with poor cardiac reserve or renal hepatic impairment, congestive heart failure, gastrointestinal disease, or infectious mononucleosis, a viral disease. To look specifically at penicillin resistance, it's the main factor reducing the efficacy of penicillins is these strains of bacteria that produce beta-lactamases. The other name for the enzyme that they produce is a penicillinase, but beta-lactamase tells you that it's actually targeting that structure in the penicillin molecule that binds onto the active site of the transpeptidase bacterial enzyme, irreversibly blocking it and making peptidoglycan less effective as a cell wall reinforcement structure. Nearly all pathogenic strains of bacteria have beta-lactamase producing variants. As a result, synthetic penicillins have been developed. They incorporate different side chains, and these may protect the beta-lactam ring from the degradative actions of beta-lactamases. One unfortunate therapeutic response seen, though, is that these synthetic penicillins tend to be less effective against bacteria that don't actually produce the beta-lactamases. So an alternative approach for the penicillins has been developed, and that's using a second chemical, clavulanic acid, in the formulation. So formulations such as augmentin contain amoxicillin and this clavulanic acid. Timentin contains ticacillin and clavulanic acid, and the clavulanic acid binds on to the beta-lactamase enzyme and inactivates it. Therefore, the amoxicillin and the ticacillin, which normally would be ineffective in that strain of bacterium, is now effective. It's important to note that the clavulanic acid is not having any effect on the bacteria, bactericidal or bacteriostatic. It is simply inactivating one of its enzymes so that the antibiotic is not degraded. With these formulations that contain the clavulanic acid, there is also unfortunately increased risk of potential adverse reactions. So then to have a look at the cephalosporins, which were also bactericidal, also inhibited bacterial cell wall synthesis. Some examples, cephalothin and cephalexin. With the cephalosporins, we talk about the generations of development. The first generation cephalosporins were effective against gram-positive organisms. The second generation were effective against gram-negatives. So the spectrum was improved by chemically altering the structure of the particular cephalosporin. With the third and fourth generation cephalosporins, these were the ones that were synthetically produced so as to be more resistant to the beta-lactamase enzymes. Cephalosporins are indicated where a person is allergic to penicillin. They are also used in prophylaxis, so we'll come back to that point when we look at prophylactic use of antibiotics, so in bowel surgery or in gynecological surgery, and for a wide variety of other infections. Once again, the drug interactions: anticoagulants, increased risk of a bleed; the non-steroidal anti-inflammatories, where once again there is some enhancement of an adverse effect, so the increased risk of gastrointestinal ulcers or an increased risk of a bleed. With probenecid, there is an increased potential for toxicity. Adverse effects of the cephalosporins, once again gastrointestinal. Of course, that killing of the normal flora bacteria leading to overgrowth of candida in the mouth and vagina. Allergic reactions. Warnings and contraindications for cephalosporins. They are used with caution in people who have impaired or low vitamin K synthesis. They can affect the liver and the production of the clotting enzymes, the clotting proteins which depend upon vitamin K for their synthesis. They're avoided, cephalosporins, in people who have sodium restrictions. There will perhaps be an anaphylaxis to the cephalosporins, bleeding disorders. They are used with caution in people with gastrointestinal disease and kidney function impairment. The antibiotics that inhibit protein synthesis in bacteria include the macrolides, a chemically consistent class of antimicrobials, so you'll see that reflected in the name, ending in THROMYCIN. So we have the erythromycin antibiotic, roxithromycin and clarithromycin. These are named because of many lactone rings, and these lactone rings contain sugar molecules. The mechanism of action of those macrolides is to inhibit bacterial RNA-dependent protein synthesis by specifically binding to the 50S ribosomal subunit that is unique to bacteria and not present in mammalian ribosomes. The macrolides are particularly used for respiratory tract infections. We'll see why very shortly. They have a slightly different spectrum to penicillins, but can also be used when there is allergy to penicillin. The macrolides are bacteriostatic. They are useful in respiratory tract infections, where it might be this microorganism, Mycoplasma. This often happens in young people who have pneumonia and then develop a residual cough. It's either the pneumonia was caused by the Mycoplasma or a secondary bacterial infection following the pneumonia, and macrolides particularly useful in targeting mycoplasmas, very, very small bacteria that are actually quite hard to culture. The adverse effects of the macrolides: gastrointestinal once again, but also CNS effects, lethargy, dizziness and headaches, as well as hypersensitivity type reactions. In addition, especially for erythromycin, killing of the normal flora microorganisms, overgrowth of candida, particularly in the mouth and vagina. The macrolides, and particularly erythromycin, affect taste sensations, they can affect hearing, they can cause a hearing loss, and they are hepatotoxic. The macrolides are metabolized via a particular isoform of cytochrome P450 enzymes, and so therefore, as you could predict, there will be numerous interactions with drugs, herbs and nutrients. So just some examples of some drugs: warfarin, increased risk of a bleed; digoxin, increased risk of the person going into a digoxin toxicity; and with the benzodiazepines, there might be a prolonged sedation with the concurrent use of a macrolide. The CNS depressant effects of the benzodiazepines will be increased. Tetracyclines are a type of antibacterial that are bacteriostatic. The tetracyclines, as their name suggests, have 4 rings in their structure. Because of their chemical consistency, this is reflected in their names. They all end in CYC, LINE. So we have tetracycline, doxycycline, and minocycline. These also inhibit protein synthesis like the macrolide antibiotics, but they reversibly block the 30S subunit of the ribosome. This will prevent the transfer RNA to the messenger RNA ribosome complex. And recall that these structures are unique in bacteria, that 30S ribosome subunit. It's not the same as the subunit in the mammalian cell, so it will be having no effect on mammalian translation. Tetracyclines are indicated for skin infections, particularly acne, and this is where it might be used long term. So we'll also look at another treatment for acne later that is not an antimicrobial. Tetracyclines are also used for respiratory tract infections. They interact with antacids, iron and mineral supplements, and calcium-containing foods. So the dosing regimen is adjusted accordingly. With resins that sequester lipids, they will also interact with the tetracyclines, and the usual way of overcoming that is to separate the doses. Oral contraceptives are less effective. There might be breakthrough bleeding. Because of this, there might be failure of contraception, so a concurrent method of contraception would be recommended while the person was on tetracyclines. Adverse effects of the tetracyclines: discoloration of the teeth if given to children who are younger than 8 years. They're also contraindicated in people who are pregnant after that week 18 and may then develop an infection. Tetracyclines would not be used. This will increase the risk of teeth discoloration in the baby. One example of one of the pioneer people who experienced this adverse effect, so that we now know to contraindicate in pregnancy, is the Queen Mother, who died a few years ago. She had the sweetest smile. She never showed her teeth, and her teeth were stained brown because of tetracyclines that she was given as a young girl. Tetracyclines also not used in people with renal impairment. Now to have a look at antibiotics that inhibit DNA synthesis. The quinolones, they are bactericidal. Once again, chemically similar class, reflected in their names, all tending to end in FLOXACIN. So we have ciprofloxacin, norfloxacin, which is used for urinary tract infections and traveller's diarrhea, gadifloxacin, moxifloxacin, and ofloxacin. The mechanism of action is to target topoisomerase enzymes. Topoisomerase 2 is DNA gyrase. This enzyme is responsible for supercoiling DNA. Without this enzyme, you cannot get DNA replication, transcription, or repair of bacterial DNA, and so this will kill that bacterial culture that's causing that infection. The quinolones are currently only available on authority script. They do have a very broad spectrum of activity and will kill strains that are highly resistant to, say, the penicillins, such as methicillin-resistant Staph aureus. So they're reserved. They're held in reserve so that resistant strains to quinolones don't develop in the population. So they are used where other antibiotics are ineffective or contraindicated. One of the problems with them, they are more expensive than other antibiotics. Quinolone interactions and adverse effects. These will inhibit the metabolism of many other drugs. They will interact with antacids, iron supplements, and sucralfate. These will all decrease the absorption of quinolones, so adjusting of dosage regimens. With the non-steroidal anti-inflammatories, there is increased risk of CNS adverse effects and convulsions, so it's used with caution in people who may be taking non-steroidal anti-inflammatories, say for arthritis. With warfarin, it will increase the anticoagulant effect if the person is concurrently taking a quinolone, and with theophylline for asthma, it will increase the plasma concentration of this particular drug, and as it has such a broad range of adverse effects, it would be important to adjust the dosage of the theophylline. The adverse effects of the quinolones: CNS effects, gastrointestinal once again, and allergic type reactions, this time a photosensitivity. The hypersensitivity is quite rare with the quinolones, as well as that CNS stimulation and an interstitial nephritis. Various miscellaneous agents: metronidazole or flagyl. We'll see it's also antifungal, but not tending to be used. As an antifungal, other azoles are used instead. The mechanism of action of metronidazole: it's particularly useful against anaerobic microorganisms. It's a cytotoxic agent. It inhibits bacterial DNA synthesis and leads directly to cell death. Metronidazole might be indicated for anaerobic infections where there is a septicemia, an abscess, infection of the bone, an osteomyelitis, infection of the tissues under the skin, a cellulitis, a CNS infection, particular protozoans such as trichomonas, a trichomoniasis, and if there is a post-operative wound. Metronidazole can be used prophylactically before the surgery or after the surgery to prevent infections. So other protozoans other than Trichomonas and that one particular species, Trichomonas vaginalis, Entamoeba and Giardia, are also quite susceptible to the effects of metronidazole because these microorganisms tend to grow in very anaerobic environments such as the large intestine and vagina. There is an anaerobic bacterium, Gardnerella vaginalis, which is also susceptible to metronidazole. The adverse effects of metronidazole: once again CNS effects, gastrointestinal effects, dry mouth, taste sensations that are altered, and a darker urine. The important adverse effects that can be quite serious are leukopenia, a reduced white cell count. Once again, the common one are vaginal candidiasis, where it kills off the normal flora microorganisms and the candida can then overgrow in the conditions that are produced in the vagina. Used with caution in people with renal or hepatic impairment, and metronidazole is taken with food to dilute it during absorption. For this reason, it might be given as a suppository to dilute it. Metronidazole will interact with alcohol and will interfere with the metabolism of alcohol. It may enhance the bleeding effects of anticoagulants, and it will reduce the effectiveness of metronidazole if it is prescribed with barbiturates. So barbiturates generally induce a particular isoform of cytochrome P450 and metabolize other drugs faster. Metronidazole is one of these, so there will be a reduced effectiveness of the antibiotic. Then to have a look at trimethoprim sulfamethoxazole combination called cotrimoxazole. Formulations such as Bactrim contain both chemicals. There is a structural similarity of sulfamethoxazole to para-aminobenzoic acid. This substance will then competitively inhibit the bacterial enzyme called dihydropteroate synthasase. This particular bacterial enzyme, very unique to bacteria and needed to incorporate PABA, PABA, or para-aminobenzoic acid into dihydrofolic acid. Because you've blocked the synthesis of dihydrofolic acid, the substrate for the next enzyme is not present, and so tetrahydrofolic acid cannot be manufactured. Without tetrahydrofolic acid, this will interfere with the enzymes that synthesize purines, and so DNA manufacture is quite inhibited with the use of this particular combination. Trimethoprim sulfamethoxazole causes hypersensitivity type reactions, a phototoxicity, the usual gastrointestinal effects, but it can also cause a fever and sore mouth, hypoglycemia, and can affect the CNS, a lowered mental state. It's used with caution in people who have HIV. The risk of the allergic reaction appears to be greater in these people. Used with caution in people with renal impairment, where the dose may need to be reduced. Used where there is a previous history of allergy to sulfonamide or trimethoprim, and used with caution in people who have severe hepatic impairment. And now to have a look at the retinoids, which are not antibacterial, but are used in treating acne. Retinoids are analogues of retinol, which is vitamin A. It's important to note that vitamin A can be toxic. In overdose, acute toxicity, it can cause peeling of the skin. However, there have been deaths from acute toxicity of vitamin A due to raised intracranial pressure. There is also chronic toxicity with vitamin A, irritability and nervousness, and as well as that, vitamin A in high doses could be mutagenic and could be teratogenic. The retinoids, as we'll see, also have a very low safety profile. For that reason, retinoids can be used topically to treat acne, particularly acne vulgaris. The retinoids actually modify cell proliferation and differentiation. The topical treatment, tretinoin gel, is also available as tretinoin oral, where it is used against promyelocytic leukemia. So as you can see, the same mechanism of action at modifying cell proliferation and differentiation, and in this case a particular neoplastic cell line. Because of this effect on proliferation and differentiation, the retinoids are contraindicated in pregnancy. They are teratogenic. There are other retinoids that are given orally for severe cystic acne, isotretinoin and acitretin. And now to have a look at antibiotic prophylaxis. So this is where people take an antibiotic. They don't actually have an active infection, but the risk of resistant strains, not important here. It's a benefit to the person to be on that prophylaxis. So they're at some particular risk. The first example is when a person has been exposed to a patient who has been diagnosed with meningococcal meningitis. If that patient may have vomited, paramedics, nursing staff, and close relatives might be given rifampicin as a prophylactic to prevent them developing meningococcal meningitis from that strain of bacterium. Penicillins are used prophylactically for people who are at risk of infective endocarditis. This is usually due to staphylococci and streptococci in the mouth or skin, and the penicillin is given prophylactically before a dental procedure because certain microorganisms, such as Streptococcus faecalis, can get into the wound, into the systemic circulation, can lodge on the valves of the heart, and can cause this infective endocarditis. Cotrimoxazole, which you'll recall is trimethoprim sulfamethoxazole, may be given to children who get repeated urinary tract infections prophylactically, while the cause of that, perhaps an anatomical problem, is investigated. Last of all, cephalosporins and metronidazole were used perioperatively, that is before surgery or after surgery. So perhaps a person might be having a bowel resection, they would be given a cephalosporin or a metronidazole beforehand and after the surgery to prevent secondary infections. So then to summarise some of the sites of action of antimicrobials, we want to find structures that are unique to bacteria. So one that is targeted is the bacterial ribosome. There are those antibiotics that target the 50S subunit, and they prevent the formation of a mature protein. So we talked about the macrolides, some other ones given there, chloramphenicol, lincosamides, oxazolidinones, and streptogrammins. Then there are those that target the 30S subunit, also unique to bacteria. So these antibiotics are not going to have any effect on the mammalian ribosome and mammalian maturation of proteins during polypeptide chain formation. The particular example that we looked at were the tetracyclines, but also aminoglycosides such as gentamicin and spectinomycin will affect the 30S subunit. Then there are those antibiotics that target unique bacterial enzymes. There are topoisomerases that are unique to bacteria, and antibiotics that inhibit these enzymes and thereby inhibit DNA replication because they inhibit the supercoiling. So there's a diagram showing a supercoiled genome of a bacterial DNA. The bacteria will be killed if that gyrating of the DNA is prevented. Some other unique enzymes found in bacteria, the ones that are used to convert para-aminobenzoic acid, incorporating it to make dihydrofolic acid. So sulfamethoxazole inhibited that enzyme, and then trimethoprim inhibited the next enzyme in the metabolic pathway, leading to the conversion of dihydrofolic acid to tetrahydrofolic acid. So without the folic acid, there was inhibited synthesis of DNA. And then last of all, those antibiotics that target the cell wall, making it less cross-linked and therefore more leaky. The bacteria die by lysis, they burst. Antibiotics such as penicillins and cephalosporins act by this mechanism. And we also said carbapenems, but these are restricted so that they are only used where there is resistance, those strains of bacteria that produce beta-lactamases.